Good afternoon. In my first video lecture with this batch, I'll be talking about chronic leukemias. The plan of the talk will be such that we'll be covering the definition of leukemia, the types of leukemia, the details of chronic leukemia, that is chronic lymphocytic leukemia and chronic myeloid leukemia. Before we understand what is chronic leukemia, it is important that we need to know what is basically leukemia. Leukemia are neoplasms that arise from the transformation of the uncommitted or the partially committed hematopoietic stem cells, and these hematopoietic stem cells are the parent stem cells or the parent cells that are formed in the red marrow, and they give rise to the different cells of the body. Leukemias can either be classified into acute leukemias or chronic leukemias. Acute leukemias have been covered in your earlier lectures. They are also of two types. You have acute lymphoblastic leukemia, in which there is a proliferation of the cells of the lymphoblastic series, and the second is the acute non-lymphoblastic or the acute myeloid leukemia, in which there is a proliferation of the cells of the myeloid series. They have the similar counterparts in the chronic leukemias, that is CLL and CML, and subleukemia and leukemic leukemia. Now coming on to the first part of the lecture, that is chronic lymphocytic leukemia. This type of leukemia is characterized by the accumulation of non-proliferating, mature appearing lymphocytes in the blood, bone marrow, lymph node and spleen. Here the key feature is non-proliferation. That means there is no proliferation of these mature appearing lymphocytes. There is cellular accumulation because of defect in apoptosis. Majority of the cells are long-lived with small fraction proliferating. The key feature here is non-proliferation, and the second important feature here is that these lymphocytes are mature appearing, means they look mature but they are not mature. They are basically functionally and biochemically immature and neoplastic in nature. They are usually of the monoclonal B cell type, that is CD5, 23 and 19, and this type of leukemia usually affects people of the elderly age group. The clinical features can be varied. At times they are asymptomatic, that is the patient has no symptoms and it is diagnosed only on routine blood examination. At times they present with lymphadenopathy, non-tender, mobile. The third most common presenting feature is heaviness in the left upper part of the abdomen, that is when there is massive splenomegaly. There is fatigue and weight loss. This occurs because of the cytokines that are released from the tumor cells. If there is anemia due to replacement of the bone marrow, they can be pallor. Bleeding manifestations are rare, as are paraneoplastic syndromes. In the laboratory diagnosis of CLL, in CBC we see that there is persistent lymphocytosis, usually more than 10 lakh in number, and on peripheral smear there are small to medium sized lymphocytes with high NC ratio. These lymphocytes are not very large, they are monotonous in appearance, and the chromatin has this characteristic feature of being clumped, checkerboard type of chromatin pattern. Now what is this checkerboard type of chromatin pattern? As you see in the chessboards, that is checkerboard chromatin pattern. The second important thing in CLL is that because there is accumulation of these non-proliferating cells, they are increased in number, but because being neoplastic and immature, they are fragile. So when we make the peripheral smear, these neoplastic cells, they rupture and present to us as smudge cells and basket cells. This is a very important key feature of all the CLLs. This is when we talk of typical or classic CLL, in which you have more than 90% of mature lymphocytes. Whereas in CLL, that is transforming into a worse prognosis, that is PLL, there is the presence of 11 to 54% of pro-lymphocytes, and in PLL there are more than 55% of pro-lymphocytes. Now what is the criteria for CLL? peripheral blood lymphocyte count more than 5 lakh. They should be B cell specific. They should be monoclonal. And in the bone marrow, lymphocytes should be more than 30%. On bone marrow biopsy, there are interstitial and nodular or mixed or diffuse infiltrate. Here on peripheral smear, I have tried to show you the smudge or the basket cell with the yellow pointer. If you can appreciate, you can see in the surrounding are small mature appearing lymphocytes, whereas in the center where the pointer is there, the arrowhead, there is one smudge cell or the basket cell. Very clearly it is seen in this peripheral smear. Now this is the photomicrograph of the bone marrow biopsy, in which you can see that there is replacement with these mature appearing lymphocytes. Now, when there is spillage of CLL in the lymph nodes, it is known as small lymphocytic lymphoma. That is the CLL counterpart in the lymph node, and it falls in the spectrum of non-Hodgkin's lymphoma. Now this is the trifine biopsy, in which you can see the nodular aggregates of cells. You can see the interstitial distribution as well as the diffuse distribution of the tumor cells. Now, prolymphocytic leukemia is a degrade or the downgradation of CLL, in which you can see they are large nucleolated lymphoid cells. That is, they are no longer monotonous in appearance. They are large with opened up chromatin, more amount of cytoplasm with the presence of a prominent nucleoli. Now coming on to the staging of CLL, we follow the rise staging. The rise staging starts from 0 to 4, and as the stage increases, the risk increases. There is lymphocytosis. In stage 1, there is lymphocytosis with lymphadenopathy. In stage 2, we add on with splenomegaly. In stage 4, there is an add-on of anemia, hemoglobin less than 10. And in stage 4, there is thrombocytopenia, in which platelets are less than 1 lakh in number. What are the poor prognostic factors in CLL? Advanced stage, atypical CLL or PLL, in which doubling time is less than 12 months, or if there is a diffuse type of bone marrow biopsy histology, increase in beta microglobulin and increase in LDH. 10% of patients of CLL develop diffuse large B-cell lymphoma, also known as the Richter syndrome. Now just a single slide regarding hairy cell leukemia. They are B-cell derived. In this, there is pancytopenia, splenomegaly. On peripheral smear, you have the typical hairy cells. And the important thing here is that on cytochemistry, they are trap positive, and the bone marrow has a honeycomb type of appearance. As you can see, these cells with projections, they are the hairy cells. Multiple myeloma will be covered in a single other lecture. So now we continue on with the myeloproliferative diseases or the neoplasia, known as MPDs. Now the key feature of MPDs are there is proliferation along with maturation. There was no proliferation in the CLL, but here there is proliferation along with maturation, with increase in both mature and immature cell. Myelodysplastic syndrome is a type of myeloproliferative disorder. Here you have proliferation with dysplasia. In this, there are 3 categories: chronic myelomonocytic leukemias, juvenile myelomonocytic leukemias, and atypical CML. Now coming on to CML. CML falls under the spectrum of chronic myeloproliferative disorder. Along with CML, you have polycythemia vera, essential thrombocythemia, chronic idiopathic myelofibrosis, chronic eosinophilic leukemia, chronic neutrophilic leukemia, systemic mastocytosis, and MP and unclassifiable. The important feature of chronic myeloid leukemia is that there is translocation of the chromosomes between 9 and 22, leading to the formation of the BCR-ABL fusion gene known as the Philadelphia chromosome. It is this BCR-ABL fusion gene that determines the prognosis of CML. If the patient is BCR-ABL fusion gene positive, the prognosis is good and there is good response to the oral medication of CML. In the clinical features, elderly people are affected, males more than females. It is characterized by the Philadelphia chromosome or the BCR-ABL fusion gene. Primarily, there is proliferation of the granulocytic cells. What are the granulocytic series? You start from the myeloblasts, the promyelocytes, then you have the myelocytes, the metamyelocytes, the band forms, the neutrophils, the eosinophils, the basophils. So here in CML, what you have? You have the proliferation of the granulocytic cells and the presence of the BCR-ABL fusion gene that leads to increase in tyrosine kinase activity, deregulation of proliferation and decreased adherence to bone marrow stroma. CML is detected by conventional cytogenetic typing, FISH and RT-PCR. The drug against BCR-ABL fusion protein is imatinib. That is a very well effective drug, once a day oral dosage. Now this photograph shows you how this ABL gene gets fused to the BCR gene, and this is how it is shown in FISH. Now there are 3 stages of CML. You have the chronic phase, you have the accelerated phase and you have the blast crisis. Patients at times recover from the chronic phase, but they may go to the accelerated phase and finally lead to blast crisis. What is blast crisis? Blast crisis is nothing but acute leukemia, either of the lymphoblastic type or of the myeloid type. Clinical features: it is insidious onset, that is slow in onset. It can be asymptomatic in 40% of the cases. There is fever, weight loss, lethargy. Because of massive splenomegaly, there is discomfort in the left upper abdomen. Usually it is non-tender, but it can be painful whenever an infarct ensues, and the magnitude of splenomegaly is directly proportional to the magnitude of leukocytosis, or they can be hepatomegaly and sternal tenderness. On peripheral smear, what do you see? On CBC and peripheral smear, in CBC there is marked granulocytic leukocytosis, more than around 50,000 to 1 lakh. There is a peak at the neutrophil myelocyte form. Remember the myeloid series. After the promyelocyte, of the metamyelocyte, the myelocyte, and the band forms, the neutrophils. So there is a peak at the neutrophil myelocyte forms. Blasts on peripheral smear are less than 3%. There can be eosinophilia, but basophilia is very prominent, and platelets are either increased or normal. The key features are a peak or at neutrophil and myelocyte forms, basophilia, normal or increased platelets, and peripheral smear shows the myeloblast less than 3%. Now this is a PS that shows you CML. You can see the promyelocytes, you can see the band forms, you can see the myelocytes. Here you can see an eosinophilic myelocyte, and you can see that platelets are not reduced in number. On bone marrow, usually not advised for CML, but what you see is a markedly hypercellular marrow. Myeloblasts less than 5% of all the nucleated cells. There is an increase in megakaryocytes. Though it's a malignancy, but there is an increase in megakaryocytes, but they are not normal functionally and biochemically. They are small with hypoelevated nucleus. There is decreased erythropoiesis. The most important feature to diagnose CML is that neutrophil alkaline phosphatase, that is a normal enzyme of a normal neutrophil, is decreased to 0 in case of CML, whereas it is increased in cases of infection and in cases of leukemoid reactions. The important differential diagnosis of CML is leukemoid reaction. In leukemoid reaction, whereas in CML you have increase in the increase in the granulocyte precursors, but basophilia, the presence of blasts are absent in peripheral smear, and neutrophil alkaline phosphatase is raised. Why? Because in leukemoid reactions the cells are normal, they are not malignant, hence the enzyme is also normal. On bone marrow aspiration, you can appreciate on the bold blue arrow here, that's the basophil, and just adjacent to the basophil is an eosinophilic myelocyte. The second figure which is there on the screen right now, what are these blue cells? This dark blue violet nucleus. Because there is too much of because there is too much of proliferation and the presence of these unwanted neoplastic cells. So macrophages are more in number to engulf these cells. These are the typical macrophages of the bone marrow known as the sea blue histiocytes or the pseudogaucher cells. Now coming on to what is accelerated phase and blast crisis. The symptoms of accelerated phase and blast crisis are same. Accelerated phase, the name itself suggests that the patient is going towards a worse prognosis or outcome, fever, night sweat, weight loss, bone pain. But on laboratory, there are two important differentiating features, that the peripheral blood basophilia will be more than 20% and peripheral blood blast will be more than 10%, along with marrow blast more than 10% in accelerated phase. Remember, in CML, peripheral blood blast were less than 3 and marrow blast were less than 5. Here basophilia more than 20, peripheral and marrow blast more than 10. And when we come to blast crisis, there is the only definition of acute leukemia that according to WHO, the bone marrow should have the presence of blast more than 20% in number. Now this is acute leukemia. It can either be of the myeloid type or of the lymphoid type. Because leukemoid reactions are a part of the differential diagnosis of CML, I have taken up 3-4 slides regarding leukemoid reaction. These are hematological findings that resemble leukemia. There is extremely high TLC with the presence of immature cell, but there are no blast cells, there is no basophilia, and NAP is very much increased. They are also of two types, myeloid and lymphoid. Myeloid leukemoid reaction you can see in diseases like empyema and septicemia, that is a condition in which the TLC is very high. You have immature cells but absence of blasts, no basophilia, and NAP will be raised. The other conditions that resemble CML are disseminated TB, metastatic tumors, ketoacidosis, or regenerating marrow in a patient with agranulocytosis. Lymphoid leukemoid reactions can occur in infections like pertussis, infectious mononucleosis, miliary TB, CMV, mumps, and tuberculosis. And this is a chart that shows you very nicely the difference between leukemoid reaction and leukemia. The clinical features will obviously be different. In leukemoid reaction, the clinical feature will be of the causative disease, whereas in leukemia, you have splenomegaly, you have lymphadenopathy, TLC will be raised in both, but usually in leukemoid reactions it is less than 1. Immature cells are less in leukemoid reaction, anemia is less, platelets are normal or increased, the bone marrow will show no blast, the NAP score will be increased, and obviously the Philadelphia chromosome is going to be absent. So in summary, we have talked about the definition of leukemia, the types of leukemia, we have talked about CLL, we have talked about CML. In CLL, we have talked about the basket cells, the prolymphocytic lymphoma, Richard syndrome. In CML, it comes under the spectrum of myeloproliferative disease that also includes polycythemia vera, essential thrombocythemia. In CML, the most important feature is the presence of the Philadelphia chromosome, that is the base radial fusion gene. And the second important feature of CML is that you have got the two Bs. What are the two Bs? You have the presence of basophilia and blast that should be less than 3% in the peripheral smear. Lab findings we have discussed, and we have also discussed how we differentiate it from the leukemoid reaction. Thank you.